Hello class, I hope that you're all doing well. Welcome to our first video in this module on psychological disorders. In this video, you're going to be learning about some of the historical perspectives on psychological disorders. You'll also be learning about some important terms, including etiology, prognosis, and diagnosis. You'll also be learning about how abnormal or atypical behavior is defined and how disorders are diagnosed. You'll be learning about a term called comorbidity, and you'll be learning about dual diagnosis. You'll be learning also about the prevalence of psychological disorders and some of the issues associated with labeling disorders. So let's get started. The American Psychiatric Association defines a mental disorder as a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes that underlie mental functioning. That seems like a reasonable definition, but it is not always easy to practice. For example, who decides whether someone has a clinically significant disturbance? Do we let people themselves decide? Do we always trust a psychiatrist or psychologist to decide? What if a therapist disagrees with another therapist? And then furthermore, does the second part of that definition reflects a dysfunction in the psychological, biological, or developmental processes add anything? In many cases, we really don't know what causes someone's psychological dysfunction, but we would consider it a disorder anyway. The APA defines 4 particular features as important components of what we would call psychological dysfunction. First, we have what are called disturbances. And these disturbances would be in our thoughts, feelings, and behaviors. And they reflect some type of biological, developmental, or psychological dysfunction. For example, hallucinations indicate biological or brain dysfunction, as you'll learn as we look at schizophrenia and the hallucinations that are often associated with that disorder, and how these are tied to differences in the brains of schizophrenic people or people with schizophrenia and those who do not have schizophrenia. And then we also have distress. Typically, the person is distressed about their symptoms. And then we also have deviance. And what this means is that the behavior, thoughts, or feelings are outside of the norms of the person's culture. In order for us to understand where we are today in our thinking about psychological disorders, it's important for us to spend some time thinking about our history. So I'm going to just give you a brief overview of how disorders have been viewed throughout history. If we go back to some early philosophers like Hippocrates, and just to give you some context, we're talking about between 460 and 377 BC. And if we think about some early philosophers like Plato and Aristotle and Galen, they had comparatively more modern views than those that were formed in later centuries when it came to psychological disorders and their causes and how people should be treated who have psychological disorders. Their views actually were similar to what we see today. They saw the need for kind treatment of people who have mental illness, and they also realized that trauma and distress often were the root causes of many disorders. They also believed that mental illness could be caused even by head injury, which we know to be true today, and that there can be a hereditary predisposition to mental illness. Now, some of you have heard about some of the views of the ancient Greeks on psychological. So the ancient Greeks, they thought that behavior could be explained in terms of 4 bodily fluids. An excess of blood caused what they called a sanguine or courageous and loving personality. An excess of phlegm caused a phlegmatic or calm personality. And too much yellow bile made one choleric or easily angered. And too much black bile made one melancholic or sad. And although this 4 fluids theory is obsolete, the terms sanguine, phlegmatic, choleric, and melancholic still persist. And although we know that these bodily fluids are not affecting human behavior, this served as the roots for some of our views today as we think about the role of biology in affecting who we are. And in particular, when we think about the role of our biology, like hormones and neurotransmitters, in affecting particular symptoms or causing symptoms of disorders. And if we fast forward from that early period of time in ancient Greece, and we move forward into the 12th and 16th centuries, this is where we see some very dramatic shifts in the conceptions of mental illness. The idea of demon possession was popular in medieval Europe, and it actually is still common in some parts of the world today. And although it conflicts with a scientific worldview, we must understand that it has some appeal. You know, think about when someone's behavior changes drastically, we say things like, that's not the person that I knew. And even that saying, we could say, has its roots perhaps in some of this view of people being possessed. Now, there's a significant problem, of course, with this approach to thinking about disorders, because people who did believe this and even do today would believe that people who have mental illness would be candidates for treatment that would not be humane. And historically, that would be being a candidate for chains and torture. As we think about the history of how people have explained the existence of some of the symptoms of psychological disorders, a common theme was the idea that these behaviors could be explained by demonic possession. Facial grimacing, head or shoulder jerking, and different vocalizations that might include things like grunting, added to the belief that evil spirits might fly out of the possessed into others. So this created some sense of fear. And it wasn't until 1885 that a French neurologist first described a neurological disorder that was characterized by involuntary movements and vocalizations. And we now know this disorder as a tic disorder called Tourette syndrome. And during the Middle Ages, mental illness was regarded as a punishment from God. And sufferers were thought to be possessed by the devil, and they were burned at the stake or thrown into penitentiaries and what we might call madhouses, where they were chained to walls or to their beds. And stories abound on the involuntary institutionalization of people who were not dangerous. Prior to the organized construction of places that were developed to hold people with mental disorders, most cities throughout Europe during the Middle Ages and the Renaissance actually reserved lodging in hotel rooms for people who had severe symptoms of psychological disorders. And hospitals were among the first institutions that housed and provided treatment to mentally ill patients. And when people had symptoms of mental disorders, they were often kept in locked wards, and it was said that this was for their own protection. And they were kept out of sight and out of mind. And so we see the first institution that was developed to care for and treat people who had mental disorders. And I use the word care for very loosely because they were not cared for in any way that we would today consider to be humane. And this was in a place that was called Bethlehem Hospital in London, England. And it actually started as a monastery and college, and then it eventually became a prison for people who had mental illness. And then it later became known as Bedlam. And some of you may have heard this term today. You may have heard the phrase as being synonymous with chaos and confusion. Someone might say it was like Bedlam. You may have heard that phrase. And so that's in reference to this hospital in London. And so this hospital included itself among the shows of London, which meant that patients were on display and they were spectacles in what we could call a human zoo. So they were very inhumanely treated. They were also sometimes allowed or encouraged to beg on the streets, and people who had lived in Bedlam in this hospital were often joined by people who were pretending to have disorders, people who were charlatans or fakes that were wanting to make money. And if you look at the image here on your screen, this is actually the top image. This is an image, it's an engraving that was created by an artist to depict what was happening in Bedlam. And it was during this time when Bedlam was the main hospital in London that people held the view that what they called madness or symptoms of any disorder was a disease of the body and not of the brain, and that it could be cured. Any disease of the body, any symptom of a psychological disorder could be cured using strong medicines to purge the individual of different bodily fluids that might be causing this disorder. And so they would do things like induce vomiting and diarrhea and induce bleeding. The skin would be blistered with caustic substances, and patients would have their heads shaved and they'd be placed in cold baths. And they would also experience these regimens as often as what the person could be able to bear. And so this then would sometimes lead to the death of the patient. And then we go into the 18th century, and this is where we see that there is a decline in this traditional treatment of mental illness, and people are then being treated in family homes. And this was because this hospital, Bethlehem, had space for only a few, really a small number of patients, about 120 people, and there was a long waiting list. And so there were many then private madhouses. And I put quotes around madhouses because these people are not mad, but they were thought to be so, and they were very much stigmatized and very mistreated. And so these private madhouses appeared around London, and they were really almost like unregulated prisons that allowed families to lock up perfectly sane people, but who maybe had some symptoms of a disorder that may have proved them to, or may have caused them to have some difficulty in their life. And at this time, what we also see is that people who had symptoms of disorders were often sent to jails, or what we might think of today as prisons. And we still see this today, where there's a significant number of people today who are in prison who have psychological disorders that where they haven't been getting the treatment that they need. So going back to the 18th century, there were many people who were put into jails who had symptoms of disorders, and it would only be the consent of people like justices of the peace or judges who would determine if the person could be let out of the jail. What we also see at this time is something called trephination, but this was something that had started well before this time, and it actually is something, believe it or not, that still continues today. So trephination is a surgical intervention, and this particular type of intervention is actually dated back to the late Paleolithic era and all the way up to this century. And trephination involves drilling a hole in the head, or there might be some scraping of the skull, and this is done using some pretty simple surgical tools. And in drilling into the skull and removing a piece of the bone, there is then the exposure of what's called dura mater. It's exposed without damage to underlying blood vessels and the brain. So there's not damage to the brain. And trephination was used and has been used to treat health problems that are associated with different intracranial diseases like epileptic seizures and migraines. And it was thought that trephination could be used to treat mental disorders by relieving pressure. And there's also evidence that it was used as a primitive form of emergency surgery as well, to remove small pieces of bone after someone had an injury. Another historical approach is exorcism and burning at the stake. And so before the 16th century, disorders like anorexia and other related disorders or nervous disorders like anxiety were treated with exorcism. And this was a gentle, quote unquote, gentle treatment compared to those who were mentally ill and deemed witches and were literally burned at the stake. And then we have the use of bleeding, where people had their veins purposely opened and blood was allowed to flow throughout the body. And so this was actually a pretty frequent practice. So that's an overview of some of the highlights of how psychological disorders and the symptoms of disorders have been viewed and treated. Overall, what we saw is a lack of human rights and the stigmatization of disorders. Today, we've seen tremendous progress, but some people still have negative attitudes and beliefs towards people who have a mental health condition. And this stigma can have some real consequences. It can lead to discrimination, and this can be obvious and direct, as someone, for example, making a negative remark about a person's mental illness or treatment, or it can be subtle. Now, people with disorders may even judge themselves. Some of the harmful effects of stigma can be very significant. First, a person may have reluctance in seeking treatment, and we know how beneficial treatment can be, and we're going to be exploring that in our next module. People who experience stigma may feel a lack of understanding from their family and their friends or people that they work with. Sometimes people may become victims of bullying or physical violence or harassment. They might also even have trouble finding housing. And then finally, when we think about stigma, people may also not be able to get health insurance that adequately covers a person's mental illness treatment. Now, this is because stigma can permeate into how policies are developed. So policies in terms of what health insurance companies decide what they're going to cover or not cover have their roots in how people view conditions. And when we think about physical health conditions, there's generally no question that a person needs treatment for the basic physical conditions that easily come to mind, and even those that are, of course, much more obscure. But when it comes to mental health, people have historically, many people have separated that from physical health. But I think it's important for us to point out here that today we are seeing some significant progress in the direction of viewing psychological disorders as falling under what we could call a medical model. So new advances in the research and treatment of mental illness, they're continuing to evolve and to move forward. And this really is to the betterment of the individual, of course, but it's to the betterment of all of us. And what you're going to see as we move forward in this module is you're going to see that psychological disorders are something that all of us are vulnerable to. So it's in all of our interest to make sure that the rights of people who have disorders are protected, because we may ourselves develop a disorder, and then also it is the humane and right thing to do. So there's been a heavy influence, or heavy emphasis, I should say, on the study of things like neurotransmitters, hormones, genetics, and the brain. And so this has led to an approach to treating disorders that has its underlying or its roots in a medical approach. And so this has led to some alternative treatments also that are geared to doing things like changing brain chemistry, addressing hormonal imbalances and neurotransmission problems in the brain. And actually, new research is focusing less on the use of prescription medications and alternative treatments. And what you're finding too is that the mental health community, as they're learning more about what's happening in the brain when people have disorders and the mind and body connection, and what roles heredity and hormones and neurotransmitters and physiology play in mental illness, then the more they are developing an understanding of how to better treat disorders. And so the mental health community is now incorporating the use of things like exercise and yoga and meditation and diet and supplements and interaction with healthy peers to increase resistance to stressors that can sometimes cause mental illnesses, and to also decrease the effects of mental illnesses that people may have because of, or may be prone to developing because of, underlying genetic predispositions. Some important terms for you to be aware of as you learn about psychological disorders include diagnosis, which involves distinguishing one illness from another. etiology, which refers to the apparent causation and the developmental history of an illness. And then we have prognosis, which is a forecast about the probable course of a psychological disorder. In other words, what we can expect the person to experience in the future when they're diagnosed with a particular disorder. So for some disorders, the prognosis can be one where a person with effective interventions like therapy may no longer have the symptoms of the disorder, but other disorders, as you'll learn, like schizophrenia, have a different prognosis where that person will always have the disorder and will instead need to be on medication and have other types of help and treatments for the rest of their lives. So how are disorders diagnosed? Well, when someone has symptoms that may indicate that they have a disorder, it's important that physical problems that might be causing the symptoms are ruled out. Oftentimes, this begins with a visit to a general practitioner, and this is often where patients will start. So they may go to their general practitioner, share some of their symptoms, and then their general practitioner will often do a physical exam to rule out potential physical causes of the disorder. And involved in this may also be a lab test. So this would be, for example, to check for specific physical issues that might be related to hormones or other variables that could be explaining some of the symptoms. And this is very important that the doctor does this to rule out any potential variables that might be causing these symptoms. So for example, a thyroid function test might be done since an underactive thyroid can cause some symptoms for depression, and an overactive thyroid can cause some symptoms of anxiety. Now, when a person does go see a psychologist or a therapist, this may happen because the person has selected on their own to go seek counseling, or they might be referred by their primary care provider. And when they do visit the psychologist or therapist, disorders are diagnosed using what's called the Diagnostic and Statistical Manual of Mental Disorders. And the one that's in current use is in the 5th edition. So that's called the DSM standing for Diagnostic and Statistical Manual, and then 5 being 5th edition. And this provides detailed information about various mental disorders, and it allows clinicians to make consistent diagnoses. And you can see here, I provided for you the classes of mental disorders. I'm going to be looking at many of these as we talk about disorders in this particular module. But let's just do a basic review of some of these classes. And many of these are classes that you've heard of. So many of you have heard of neurodevelopmental disorders, and these include disorders like autism spectrum disorder, attention deficit hyperactivity disorder, and learning disorders. You may have also heard of schizophrenia, and we'll be looking at that in this module. And this is a class of disorders that cause detachment from reality, and a person may experience delusions and hallucinations and disorganized speech. Now, the most notable example of disorders that fall within this class is schizophrenia, but there are other disorders that can be associated with detachment from reality. Another class is bipolar disorder, and this is one that many of you have also heard of, and we'll be looking at that in this module as well. And then there's another class, which is depressive disorders. This is another category of disorders that we'll be looking at. We're going to be looking at major depressive disorder, and we'll also be looking at seasonal affective disorder. And there are other depressive disorders that fall within this particular class. Another class of disorders that many of you are probably very familiar with, and this is because it's actually pretty common when we compare this category to other categories, and that's anxiety disorders. We'll be looking at generalized anxiety disorder in this module, and we'll also be looking at panic disorder and specific types of phobias. Another class is obsessive compulsive disorder and related disorders. And this is where a person has preoccupations or obsessions and then repetitive thoughts and actions. Most of you have probably heard of obsessive compulsive disorder. We'll look at the symptoms of this, and we'll also be looking at those variables that can contribute to its development. We'll also be looking at hoarding disorder. You've also likely heard of PTSD. This falls underneath the class of trauma and stressor related disorders. We'll be looking at PTSD, and we'll also be looking at what variables in the environment can contribute to its development. Many of you have probably heard of multiple personality disorder, and that's an old phrase that is or was used to describe what's today known as dissociative identity disorder. And we'll be looking at that disorder in this module, and we'll look at other types of dissociative disorders. And these are disorders where a person's sense of self is disrupted. And then we have other classes like sexual dysfunction, gender dysphoria, which is where a person experiences distress that comes along with a person's stated desire to be another gender. We also have another category, which is disruptive and impulse control and conduct disorders. And these are disorders that are related to emotional and behavioral self-control. And this can include disorders ranging from kleptomania to intermittent explosive disorder. And then another class is one that many of you are probably familiar with. Perhaps you know someone with an addiction, and this is something that is one of the most common, more common disorders that we're seeing today, especially as we think about the abuse of Oxycontin and hydrocodone and other opiates. And so we have substance-related and addictive disorders. But this class does not only include abuse or addiction to alcohol and drugs, it also includes gambling disorder. And we also have neurocognitive disorders. And these are disorders that affect a person's ability to think and reason. And these are acquired rather than developmental. So in other words, these are disorders that a person had never had symptoms of prior to developing symptoms of this disorder, which is different from disorders like learning disorders or autism spectrum disorder that we looked at just a few moments ago. So a person may develop a condition that's related to a traumatic brain injury or Alzheimer's disease. And you can think about recent examples of traumatic brain injury being described in the news. I think of, for example, football players who may experience repeated concussion and then how this changes their behaviors. Or you may think about people who are in combat and experience traumatic brain injury, which can have an effect on their ability to remember, affect their emotions, their ability to concentrate and focus. And Alzheimer's disease is also included here. And we have another class that we're going to be looking at in this module, which is personality disorders. And these are long-lasting patterns of emotional instability. These are traits and characteristics that are woven throughout that person's being. So rather than their symptoms being disconnected from who they are, they become fundamental to how that person thinks and feels and behaves. And these disorders can cause some significant problems in a person's life and in their relationships. We'll be looking at borderline personality disorder, antisocial personality disorder, and narcissistic personality disorder. And these are just 3 examples. There are many. We also have paraphilic disorders and then other mental disorders. And these are disorders that are due to other medical conditions, and they may not meet the full criteria for one of those that we've just looked at. So we're going to be looking at many disorders in this module. We'll be taking a look at the symptoms. We'll be looking at who tends to be the most vulnerable to developing these disorders. And then we'll also be taking a look at some of the common causes or factors that may contribute to the development of some of these disorders. I will tell you that the Northeast State Library does have a copy of the DSM-5, and this is a reference book, so you can't check it out, but it is available in the library. It's very interesting. I'd encourage each of you to, if you are interested in learning more about disorders, to take a look at that book. You can find pieces of this manual online, although you can't find it available for free in its entirety, but you can find some of it. You can also, of course, purchase the manual if you're really interested in learning more about disorders. I've found that you can find some pretty inexpensive or relatively inexpensive versions of it used, but of course that varies depending upon the demand and the supply. I know that new, it's pretty expensive, but again, there are some used versions. But remember, if you want to know the latest, you need to be able to have access to the DSM-5. Earlier editions aren't going to give you the up-to-date information, and that's not what clinicians use today. They use the DSM-5 today. Another class of disorders are somatic symptom and related disorders. And a person who has one of these disorders can have physical symptoms that can cause major emotional distress and problems functioning, but they may or may not actually have a medical condition that's associated with those symptoms. I think that this is in particular something that we are seeing with coronavirus. I think we saw this especially in the beginning when people didn't know what coronavirus was and they were very worried about the potential of getting very sick and ending up on a ventilator. Of course, there is still worries that people have today, but the worries were omnipresent back when this particular disease became a pandemic in March of 2020. And as we would watch the news and we would see that one of the symptoms was trouble breathing, it was very normal then for people to worry. That's a tremendous fear that each of us could probably have, the idea that we would have trouble breathing. And so some people reported feeling like they were having trouble breathing when they didn't have the disorder, or disease, I should say. And so if you were watching the news and you were seeing these symptoms and you were seeing all of the anxiety surrounding the symptoms of coronavirus, and you were feeling anxiety about this virus, it would make sense that symptoms that a person may have that could be connected to coronavirus, a person may then connect in their mind to that virus thinking that they had it or worrying that they had it. Also, we have another class, which is feeding and eating disorders. And these include disturbances that are related to eating, which can affect a person's nutrition and their health. Anorexia, binge eating disorder, bulimia nervosa, these are examples of feeding and eating disorders. Anorexia nervosa and bulimia have been in the Diagnostic and Statistical Manual for many years, whereas binge eating disorder is relatively recent as a recognized disorder. And I think this is a great opportunity then for us to think about how the Diagnostic and Statistical Manual is a continuously evolving manual. So each time that a new edition comes out, there are new disorders, or there may be a removal of certain disorders based upon what the research has to say. And there's inclusion of new information because that manual not only provides diagnostic criteria, it also provides some information that are related to the prevalence. In other words, who tends to get it? Is it more often in males, in females? Is it more often occurring in a particular ethnic group? Or is it more often occurring among a particular age group? And then you also will find that there will be some other factors that are included, like some of the major common causes. And so as new research emerges, then this is included in the manual. And then old information will be taken out as new information is replacing it. For example, bipolar disorder in children was a disorder that had been diagnosed in children, in some children, prior to the DSM-5, the 5th edition coming out. But when that new edition came out, that particular edition removed bipolar disorder in children and instead identified the symptoms that kids were experiencing that had been included under that disorder as another more appropriate disorder for kids. And this is because that bipolar disorder in children is distinct from bipolar disorder in adults. The symptoms are distinct, and it made sense to remove that diagnosis, especially because the diagnosis is connected then to how the disorder is treated. And again, as new research emerges, we see changes. You also would see in the older manual a disorder called Asperger's syndrome. And today, instead of that, we see autism spectrum disorder, which includes the symptoms of Asperger's disorder, but that's considered to be a very mild form of autism, where we can see a spectrum of symptoms related to autism, where people may have very mild symptoms, or they may have much stronger or more intense symptoms that are affecting that person's life. We also used to see in the manual schizophrenia as having major subtypes, like, for example, paranoid schizophrenia, catatonic schizophrenia. Those are just a couple of examples. Instead, now we just have one major disorder of schizophrenia. So research as it emerges affects how disorders are described in the manual and therefore how disorders are diagnosed and the criteria that are used. Another class of disorders are elimination disorders, and then we have sleep-wake disorders that include sleep disorders including insomnia and sleep apnea and even restless leg syndrome. Here's an example of what the diagnostic criteria looks like for a disorder in the Diagnostic and Statistical Manual. You'll see here that it says Cluster B personality disorders, and this is because personality disorders in particular are organized into 3 groups in the DSM, and this is because these clusters share key features. But more importantly for you, I wanted to show you what the diagnostic criteria look like. And you'll find that this is how they're laid out in the DSM for each disorder. And you'll find that the DSM indicates typically that a person must fulfill certain criteria or a certain number of criteria in order to be diagnosed. So for example, this states a pervasive pattern of disregard for and violation of the rights of others occurring since age 15, as indicated by 3 or more of the following. And then there are additional criteria in B, C, and D. And then you'll also see a code, and this is used for diagnosis, and this is what's submitted to insurance. And the criteria that you see are based upon the research that's been done around this disorder. And again, as new research emerges, then you're going to find that there are new symptoms that might be included, or there might be a modification of symptoms or removal of symptoms or even disorders. The DSM-5 is what is used among psychologists and therapists and counselors in diagnosing psychological disorders. But around the world, we also have what's called the ICD, and it's the ICD-11 that's in current use. 11 is the 11th edition, and ICD stands for International Classification of Diseases. This particular manual not only includes psychological disorders, but it also includes diseases and illnesses. So this is a manual that was developed by the World Health Organization, and it's continuously updated, so that's why it's in the 11th edition. And the codes within this manual are used for billing, and there actually is a plan to integrate the 2 diagnostic systems. This chart shows you the lifetime prevalence of any psychological disorder. So in other words, about 44% of the population will have a disorder in their lifetime. And when we say disorder, we're talking about a disorder that falls within any of those classes that I just shared with you. The more common disorders include those that are related to substance use. You can see here that the lifetime prevalence is about 24%. And then we see anxiety at around 19%. And around 19% of people are going to experience disorders like generalized anxiety disorder, phobias. They may also experience agoraphobia, panic disorder. So those are the disorders that fall under anxiety disorders. And then we see mood disorders. So 15% of the population will experience a mood disorder in their lifetime. And then for schizophrenic disorders, about 1% of the population will experience this disorder in their lifetime. So this provides us with insight into why it's important for us to know about the symptoms of disorders. You may not develop a disorder in your lifetime, but it's very likely that someone in your family or a close friend will. And for those of you who are going into a health-related profession, knowing about the symptoms and causes and prevalence of disorders is going to be helpful information for you. If you're interested in learning more about disorders, because this is just one module, and you can learn much more about disorders than what you will learn in this module, I would encourage you when you transfer to another school to take a class like abnormal psychology. It's a great class for you to take regardless of your major, but especially if you are majoring in, of course, psychology, and it would likely be required, but also if you're majoring in any of the health sciences. These are often having their roots in biological causes. So oftentimes disorders are connected to things like neurotransmitters, brain function, and hormones. And not to mention, because you're going to be interacting with people and nearly half of the population will have a disorder in their lifetime, understanding disorders is going to help you to be more effective in working with patients. In any given year, 1 in 4 Americans will suffer from a diagnosable psychological disorder, and you can see the prevalence rates for common mental disorders that are provided here, and the size of the circle is in proportion with the frequency of the disorder. So you'll see that depression, the rate is 6.7%, and for specific phobias, which we'll be looking at, the rate is at 8.7%. For ADHD in adults, the rate is 4.1%. So this gives you an idea of how common different mental disorders are. And again, if we think about the lifetime prevalence, about half of the population will meet the criteria for a psychological disorder in their lifetime. And the numbers here are representing the annual prevalence. So this is not the lifetime prevalence, but annually, how often these disorders are diagnosed. Naming is important to clinicians because it provides terms that they can use to both define the disorder and describe how it might be treated. There are 2 terms that can be used when 2 or more conditions appear in the same person at the same time. We have dual diagnosis and co-occurring disorders. The term dual diagnosis could be applied when a person has 2 or more psychological disorders at the same time, but it also is a broader term that could apply to any combination of physical conditions that apply to one person. So, for example, someone with diabetes and heart disease might have a dual diagnosis. Someone with cancer and migraines might also have a dual diagnosis. And someone with depression and anxiety might also have a dual diagnosis. So anytime that clinicians can diagnose 2 separate conditions, they might use this term. The term co-occurring refers to a mental health issue that comes as a result of or contributes to an addiction to alcohol or drugs. So for some people, mental illness sparks the need to use and abuse drugs, as these substances can function as a form of symptom control. And this is not that uncommon. It's actually very common. The person might feel that with the substance that they're abusing, they're capable of handling the difficulties that the mental health issue brings. For others, mental health issues come about due to drug abuse and the brain damage that drug abuse can cause. While labeling of disorders is very important, as this helps to establish distinct diagnostic categories and helps patients receive effective treatment, some suggest that this can be dangerous or overly prejudicial. So a study in 1972 that was conducted by a researcher named David Rosenhan supports this idea. In his study, Rosenhan asked healthy participants to enter a psychiatric hospital and complained that they were hearing voices. They actually entered several psychiatric hospitals. All of the participants were admitted into the hospitals and they were diagnosed with either schizophrenia or bipolar disorder. At the time, it was called manic depression. Once they were admitted, these patients, so-called patients, stopped pretending to be ill or to have the symptoms of the disorder, and they acted as they normally would. But the hospital staff's interpretation of their normal behavior was skewed by the label of mental illness. They had been diagnosed and labeled, and those labels stuck, even when actual symptoms disappeared. So what do you think? Do you think that labels have the possibility of affecting how people see themselves and how others treat them? An overall underlying concept in the study of mental disorders is that of abnormality. I think it's important for us to first think about the word abnormal. I wonder, as we think about some of the stigma that's still associated with psychological disorders and seeking treatment for disorders, do you think that the word abnormal, which is often used when describing psychological disorders and their symptoms, can have an effect on contributing to the stigma? Do you think that the word abnormal is value laden? In other words, do you think that because of words like abnormal or disorder, people may, to some degree, feel averse to talking about their symptoms or seeking treatment because most people don't want to be considered abnormal or that how they think or feel is abnormal or disordered? Perhaps an alternative term that we could use is the term atypical. That is much less value laden, and it's one that you'll often find in the research related to child development. This is frequently found in the research in child development because of the negative connotations the word abnormal has, and because this may make parents less likely to seek treatment for their child if they think that there's something abnormal. Or it may also, if we use the term abnormal, affect how a child views themselves, contributing to more negative views. It may also affect how teachers and other people in the child's life interact with the child. Perhaps the same should be applied to adults. Perhaps adults may be more likely to see themselves differently if we reconsider the language that's used to describe the symptoms of psychological disorders. Language does matter. I know that for myself, anytime I say the phrase mental illness or mental health issue or psychological disorder, I wonder how phrases like those affect how people who have disorders like depression, schizophrenia, bipolar disorder, or any other disorder may see themselves, or how those around them who may already hold stigmatizing views of disorders may see them. As you learn about psychological disorders in this module, you'll note that different psychological perspectives view the causes of disorders differently. For example, the sociocultural perspective considers abnormal or atypical or normal or typical behavior as a product of behavioral shaping within the context of such things as family influences, the social group to which one belongs, and the culture within which family and the social group exist. So, for example, anorexia nervosa and bulimia nervosa are most often found in Western societies. Think about the cultural variables that may contribute to the development of these disorders, and contrast those variables to those that you might find or not find in cultures throughout much of Africa. It's important for each clinician to consider cultural relativity. In other words, it's important to consider the norms and customs of another culture when diagnosing a person from that culture with a disorder. It's also important to note that not every culture has the same disorders. We have what are called culture-bound syndromes. Culture-bound syndromes would be those that where people lack a familiarity of the condition to people in other cultures. So they're unique to that particular culture. And there are no demonstrable biochemical or other explanations that are within that person that are inherent to their physical being. So they're not due to things like issues related to the brain, hormones, or neurotransmitters. And the condition is usually recognized and treated by the folk medicine of the culture. An example of a culture-bound syndrome is one that you would find among some Native Americans, and it's called Wendigo. And this is a morbid state of anxiety with fears of becoming a cannibal. And this is unique only to some specific Native American tribes. And then we have another, which is called Amok. And the region that we tend to see this in is in Malaysia. And a person who has this, and again, this is very unique to this particular culture, is going to have a dissociative episode where they have a period of withdrawal and then brooding and then This is followed by an outburst of violent, aggressive, or even homicidal behavior. And this is often a response to a perceived slight. So this is unique to people, some people within that particular culture. And this is something that you wouldn't find in other places in the world. So this is why we call it culture bound. And we have additional perspectives. So we have, for example, the biological model, which says that behavior or atypical, abnormal behavior is caused by biological changes in the chemical, structural, or genetic systems of the body. So the focus is on what are the underlying biological explanations for why that person has these symptoms. And so then the approach to treatment is going to be one that is biological. It may involve medication, it may involve electroconvulsive shock therapy, it may involve deep brain stimulation, just to name a few. And then we also have the psychodynamic perspective. And this particular perspective says that psychological disorder symptoms are coming from the unconscious. So these may be coming from repressed conflicts and urges that are fighting to become conscious. And if you'll remember, you learned about Freud and how Freud emphasized the role of the unconscious in shaping our behavior. We also have additional people who fall within that framework of thinking. We can think about people like Carl Jung. We can think about people like Karen Horney and Adler. And then we have the behavioral perspective. And this perspective suggests that psychological disordered symptoms are learned. And so we may see a focus here on disorders like phobias. We can think of the role of classical conditioning in the development of phobias. You'll remember learning about little Albert and how he developed that irrational fear of the white rat. And then he generalized that fear to all things white and furry. We could also think about how we may, for example, develop some symptoms of a disorder because that particular behavior that's associated with the disorder is leading to something that feels good. So for example, a person may have feelings of anxiety, and then they may reduce those feelings of anxiety by using alcohol or drugs. And so that abuse of that substance becomes what we would call negatively reinforcing. It's negatively reinforcing because you're removing something that the person does not like. It's reinforcing because the behavior is maintained. So what is being removed that the person doesn't like? Those feelings of anxiety. And when that happens, the person is going to likely continue to use that substance in order to continue that removal of those feelings of anxiety. We also have the cognitive perspective. And this perspective focuses on the way that we think about things and how irrational beliefs can lead to some symptoms of psychological disorders. Think about yourself, and perhaps you have felt anxious before. And if you reflect on some of the causes of that anxiety, you might think about how that anxiety can come from some irrational thoughts. Sometimes that can be due to overgeneralization. Maybe you don't do well on one test and you say, I'm a failure as a student. And of course, that's not true that you're a failure as a student. This is just one instance of not doing well. But when we overgeneralize, that's an irrational thought. We also find that there are additional maladaptive ways of thinking that can lead to anxiety and other disorders. And we'll be looking at those in this module. And then we have what's called the biopsychosocial model. And this particular model focuses on the combined interacting forces of our biology, the psychological forces and influences, social influences, and cultural influences. And so when you go to a clinician, when you see a psychologist, a therapist, or a counselor, you'll find that they may hold one perspective as being more significant than another in affecting the development of certain disorders. And so this then would affect the treatment approach that that psychologist, therapist, or counselor takes. So these are just a few of the major perspectives, and you'll find that some of these will be combined as well. There's a very popular one that is very well supported by research, and this is the cognitive behavioral perspective. in that if we can change our thinking, this then can change our behaviors, which then results in different outcomes in our environment, which then can help to contribute to further changes in our thinking. And then we also have what's called the diathesis stress model of disorders. And what this does is it integrates those stressors that we may be experiencing in our environment, our genetic vulnerability or other biological predispositions. And it suggests that when you combine these things together, we have an increased risk of developing a disorder. So, for example, a person may have a genetic predisposition to developing depression. When you combine that with childhood trauma, there is an increased vulnerability to the mental disorder. And when we then combine that with having an inability to cope with stressful circumstances, we have an even higher probability of the mental disorder. So we see opportunities to intervene here. Number one, by reducing childhood trauma. And there are many programs, both federal, state, and through nonprofits, that have been developed to reduce the instance of childhood trauma, because we know that there can be some very significant lifelong consequences. But we know that not all childhood trauma can be avoided, even with the most well-intentioned and well-developed programs. So if we can develop programs and strategies to help kids to develop healthy coping strategies so that they can become more resilient to the effects of these stressful traumas that they experience, then we can see a decreased probability of the development of mental disorders. So what have you learned about? You've learned about the historical perspectives on psychological disorders, and you've also learned about some important terms, that of etiology, prognosis, and diagnosis. You also learned about how abnormal or atypical behavior is defined. And you learned about the DSM-5 and the ICD-11. You learned about the major classes of disorders that are within the DSM-5 and how the DSM-5 is used. You also learned about co-occurring disorders and dual diagnosis. And you learned about the prevalence of psychological disorders and just how common they are. And you learned about some of the pros and cons associated with labeling. Please be sure to continue to watch the module videos so that you can learn about some very significant and common disorders that exist within our population. In these videos, you'll be learning about the symptoms of disorders and some of the major causes, as well as the prevalence. As always, after watching this video, after reading your textbook, please don't hesitate to let me know what questions you have.